Type 1 diabetes. Type 1 diabetes is characterized by destruction of the pancreatic beta cells. It is thought that combined genetic, immunologic, and possibly environmental, example viral factors, contribute to beta cell destruction. Although the events that lead to beta cell destruction are not fully understood, it is generally accepted that a genetic susceptibility is a common underlying factor in the development of type 1 diabetes. People do not inherit type 1 diabetes itself, rather, they inherit a genetic predisposition or tendency toward developing type 1 diabetes. This genetic tendency has been found in people with certain HLA, that is human leukocyte antigen types. HLA refers to a cluster of genes responsible for transplantation antigens and other immune processes. Type 1 diabetes exhibit specific HLA types, that is DR3 or DR4, that is capital letter D, capital letter R 3, or capital letter D, capital letter R 4. The risk of developing type 1 diabetes is increased 3 to 5 times in people who have one of these two HLA types. The risk increases 10 to 20 times in people who have both DR3 and DR4 HLA types as compared with the general population. Immune mediated diabetes commonly develops during childhood and adolescence, but it can occur at any age. There is also evidence of autoimmune response in type 1 diabetes. This is an abnormal response in which antibodies are directed against normal tissues of the body, responding to these tissues as if they are foreign. Autoantibodies against islet cells and against endogenous, that is internal insulin, have been detected in people at the time of diagnosis and even several years before the development of clinical signs of type 1 diabetes. In addition to genetic and immunologic components, environmental factors such as viruses or toxins that may initiate destruction of beta cell are being investigated. Regardless of the specific etiology, the destruction of the beta cell results in decreased insulin production, unchecked glucose production by the liver, and fasting hyperglycemia. In addition, glucose derived from food cannot be stored in the liver but instead remains in the bloodstream and contributes to postprandial hyperglycemia, that is after meals. If the concentration of glucose in the blood exceeds the renal threshold for glucose, usually 180 to 200 mg per deciliter, the kidneys may not reabsorb all the filtered glucose. The glucose then appears in the urine, that is called glucosuria. GLUCOSURA, glucosuria. When excess glucose is excreted in the urine, it is accompanied by excessive loss of fluid and electrolytes. This is called osmotic diuresis. Because insulin normally inhibits glycogenolysis, that is breakdown of stored glucose, and gluconeogenesis, production of new glucose from amino acids and other substrates. In people with insulin deficiency, these processes occur in an unrestrained fashion and contribute further to hyperglycemia. In addition, fat breakdown occurs, resulting in an increased production of ketone bodies, which are the byproducts of fat breakdown. Ketone bodies are acids that disturb the acid-base balance of the body. When they accumulate in excessive amounts, the resulting DKA may cause signs and symptoms such as abdominal pain, nausea, vomiting, hyperventilation, and a fruity breath odor, that is Kussmaul breathing. And if left untreated, altered level of consciousness, coma, and death. Initiation of insulin treatment along with fluid and electrolyte as needed is essential to treat hyperglycemia and DKA and rapidly improves the metabolic abnormalities. So type 1 diabetes causes due to destruction of pancreatic beta cells. And the previous classifications of type 1 diabetes also called juvenile diabetes, juvenile onset diabetes, ketosis prone diabetes, brittle diabetes, or insulin dependent diabetes mellitus, IDDM. Thank you.